So Red has been a structural guy for 1 year more than me. He's extremely old, and Red has been doing this, and with every new device, every new technology, and has been very deeply immersed in the field and travels widely. So we wanted to. I know a lot of people. We went through the evaluations last night. A lot of people were on us for cases. We love the cases, show more cases, whatever. So we wanted to have somebody who's experienced say, these are 3 cases, just another opportunity to see some cases. 3 cases I'm never going to forget, and cases that I learned from. So Rita's going to speak about that.
Thank you, Eric. It's actually more than 3 cases. It's 3 lessons, but it is tons of cases, you will see. It's just sad because when you start to teach lesson, it's because you're becoming older, as you said, Eric. So lesson 1 from my practice: think outside the box. And let's see this case. So the case, it's named the domino effect, and you will understand. So this is a 60-year-old male with Hodgkin lymphoma treated with, say, a long time ago, 2004. Evolution was a bit unusual with acute constriction. He was treated with partial pericardiectomy at the time. And then he presented recurrent reconstruction with an external right atrial tumor, potentially malign. He was at the end operated in 2016, but it was at the end benign. This is not the point of the case. But multiple complications after the surgery, persistent AFib, spontaneous left pneumothorax on heparin requiring surgical drainage, bilateral phrenic nerve palsy, acute renal failure. And then on post-op day 40, he developed a massive right pneumothorax associated with transient hypotension at the time after repositioning of a dialysis catheter in the right internal jugular vein. Angioscan at the time demonstrated distal perforation of the SVC that you can see here. So we have the catheter in the SVC, the right internal jugular vein, and you have the perforation here. So at this point, the patient is stabilized, and the surgeon is showing up in the hybrid room where I was working that day to close appendage. So with echo guidance, anesthesia, all the right setup to do the procedure. So surgeon is coming, is trying to convince us to find an endovascular solution for this perforation. He said that he doesn't want to operate anymore. And to be honest, I was not really happy because it was a big day for me. I think it was 4 or 5 cases of appendage occlusion, but the setting was appropriate. I was in the hybrid room, I was with anesthesia, T guidance. So I said, yeah, why not? Let's put a cover stent. So patient is coming the room, and because we have echo by chance that day, we dropped the TE probe, and this is what we saw. So this is the SVC, and this is the flow in the SVC. So what do you think? Do you see something is concerning? Is it unusual for you? Do you have a time to ask question, Eric? Or I should go? Probably you should probably go. So,
RPA flow to SVC?
Pardon me?
RPA flow to the SVC?
No, it's not PA flow to the SVC. It seems to come from the...
It's right behind SVC, so RPA is right behind SVC.
Yeah, it's maybe coming from the RPA. So there's flow, but the thing that I think we should note here, it's flow. It's not going outside SVC. It's going inside SVC. And,
From the PA to the SVC.
yeah.
But also in a venous bleed that's slow, it may be very difficult to see. Just because you don't see flow doesn't mean there's not something leaking.
Yeah.
So I mean, yeah.
But it was unusual. So next step for us was to do a Doppler analysis of that flow, and this is what we saw. So this is a systolo-diastolic flow, but the maximal flow is at the beginning of diastole. So from this, it was clear what was the source for bleeding for us. Is it clear for you? So the only thing that I know with that pattern of flow, it's coronary flow. So when we saw that, maximal flow in diastole, I said to myself, it should come from the coronary. So next step was to shoot the coronary. And this is the left was normal, but this is the right coronary artery. It's a huge fistula. So right coronary fistula, going the right thorax and going back in the SVC. And it's why this patient was alive. It was autotransfusion. Blood is going from the coronary artery back to the SVC. So the treatment was not to close the SVC in this case, but more to put a cover stent in the coronary artery. This is what we did, and it was very effective to seal the bleeding. But SVC was still bleeding. This is the injection SVC. We used what we had at the time in the cath lab. It was a duct to occluder. It was possible to close that very efficiently, no more flow. And because we were in the hybrid room, we even drained the right hemothorax. And this is the view of the device in the SVC after the drainage of the hemothorax. So I learned many things from this case. I learned that one bleeding can hide another one. Echo guiding is often more useful than we think. So I mean, I think I was lucky that day because I was working and echo was available. But in theory, the thing that I was planning to do is just to put a cover stand, probably without echo guidance, and it would probably kill this patient because you were preventing the autotransfusion. And it's always good a good thing to perform structural intervention in the hybrid room. Any comments on this case?
What cover stent would you have used?
It was Abbott cover stent. It's coronary stent that we have in the cath lab, in all cath lab. All right.
How did manipulation of the dialysis catheter cause a cord hurt? I don't understand.
I don't understand, me too. I think it was just red earring.
Probably was coincidental.
I think so.
I think manipulation of the catheter, you thought pneumothorax, but it was probably already there.
I think so. So lesson 2, patient need to be followed well and at long-term after device. So it's because this is all single-digit number in my practice, but this is a phenomenal case, I think. 60 years old male with hypertension, paroxysmal AFib, mild primary hypertension, chronic low platelet count. This patient was referred for ASD closure and LA occlusion because of the low platelet counts and the difficulty to anticoagulate it. I did that procedure in November 2012. I put at the time a 20 millimeter amulette device in the appendage. And on the way back with the same delivery catheter, I delivered an emplaster septal occluder. It was a 24 millimeter device. Because after LA occlusion, we do a systematic TE at 1 month follow-up. I'm showing you the 1 month follow-up TE. So this is it. This is the emplaster septal occluder. I mean, that's a huge, I'm typically not doing TE at follow-up for ASD occluder, only transthoracic, but I'm doing that for after appendage occlusion. So this is potentially something that I never saw that before, but I'm never doing TE after ASD closure. And this is a huge thrombus, but I mean, interestingly, it's only on the left side of the occluder. Why not on the right side? Let me show you now the appendage occluder. See, there's a huge thrombus also, but both on the left side. So what do you think? I mean, there's something wrong. What we should do, we should probably anticoagulate. And this is exactly what we did. We put this patient on warfarin. This is 4 months after anticoagulation. It's persistent thrombus, but not anymore at 6 months. Okay, so it was effective, the anticoagulation. The patient is still anticoagulated. I'm not sure that will stop. Another case, 75 years old man, diabetic, hypertensive, dyslipidemic, ASD closure in 2009. It was a 24 millimeter emplaster septal occluder. 4 years after, he's coming back in the emergency room with confusion and fever. So what do you think? I guess you think about an infection. It was an infection. Blood culture were positive. CT scan revealed cerebral abscess. and transthoracic echo and TE revealed this. So this is the occluder well in place. There's no residual flow in the septum, but see there's something wrong here. Let me zoom on this. So remember, it's 4 years after the procedure, 4 years. So this is it. So what do you think? I think it's an infection. It's quite clear. What we should do, I think it was clear. It was quite clear for us it requires surgery, and this is the device. So this is the device. This is what you saw on echo. But very interestingly, this device is not fully covered. It's covered. It's well covered here, but in this part of the device, it's not covered. For any reason why, I don't know. But this patient came back 4 years after. Yes?
Did that cause you to change your recommendations for antibiotic prophylaxis afterwards? Or?
The official recommendation is 6 months. I'm typically suggesting 1 year. Since that case, to be honest, I don't know what to do anymore.
That's the second case like that I've seen. I mean, 7 years, the other case is a case from out west, 7 years later.
So that case is published now anyway. So we have expert here in this field. What we should take, what we should take from this case?
Just one, pre-procedure, was there mitral valve prolapse?
No, mitral valve normal. No,
Did not buckle or anything?
no.
Because one of the reasons is that if the mitral valve even entry leaflet buckles,
Yeah.
it keeps hitting the device and that area may not get it. You realize that risk of things like defended by viral sign. There's a publication from Texas Children's Hospital on that.
But let's see my next case.
Yeah, Reid. The case before with a large thrombus on the
Yeah.
device in LA. Did you talk to your surgical team? I mean, because it's a huge clot burden in the left atrium, both of them. It wasn't flipping all around, but so did you talk about, because you removed this because it was infected. This patient, you removed the
Exactly,
device
because it was infected.
Yeah. Okay. So so does that come up? And the reason I'm bringing this up is we had an individual that was on the lung transplant lady, and she ended up having PFO, had a line in for her. You know, she was going to have a line after lung transplant. So the surgeon said, "Can you guys just go ahead and close the PFO? It changes the way we do our surgery because it's lung transplant, blah blah blah, and all this stuff." So he says, "Yeah, sure." So we actually used the Helix device, which is not supposed to have thrombogenicity, and so we closed it. She got her lung transplant. She was on her immunosuppressive medications, and she was up and down as far as taking what we would normally recommend after the device closure. And she came back, and that picture of the left atrial disc, she had huge thrombus on her left atrial disc that was flipping all around her left atrium. And ultimately, the surgeon went in and removed the device because of the unknown terrible consequences of an emboli for the clot burden. So that's why I was just thinking in that patient, it worked well, you did anticoagulation, but was there a consideration to say, go in, surgeons take that device out, close the ASD?
To be honest, it was
atrial appendage, boom.
Yeah, to be honest, it was a large thrombus, but it was a stable thrombus, and we were confident that anticoagulation that we can potentially dissolve that. So it is exactly what happened.
Yeah, because it's mass and it's also...
It's massive, but stable. Yeah.
Okay.
Now, 70 years old woman, rheumatoid arthritis, hypertension, ASD closure with a 26 millimeter device. It was in 2006, back at the emergency room 1 month after the procedure for rapid palpitation. This is the ECG. I'm showing you the baseline ECG of this woman. I don't know what you think. It was interpreted at the beginning as AFib, but after careful look of this ECG, we thought it was probably flutter, so we sent this patient for an EP study, and we found actually that it was a micro re-entry around the device in the right atrium. So that was easily ablatable. So it was 1 month after the procedure. So we did that EP study because of the aspect of re-entry on ECG, but also because that patient did not present any history of AFib in the past. She was 70 years old, and she's coming back 1 month after the procedure. Last vignette, this is a 26 years old tall and thin woman, ASD closure with a large 34 millimeter ASD occluder, routine TE 3 months after the procedure. This is the routine follow-up for us after ASD occlusion. No residual shunt, but new mild to moderate MR. This is a patient with previous prolapse that you were talking about. This is the transthoracic echo at 3 months. So what do you see here? It's a well-placed device, but with each contraction, it seems to touch the mitral valve. And this is exactly the site of MR. Mild to moderate MR. So it was a perforation in the anterior leaflet of the mitral valve. What we should do, I guess I will tell you, we just closely follow up her. And last transthoracic echo, it was mild MR. I guess it can be potentially up to moderate, but it was very stable. So we just watchful waiting. So several learning points from all the small case that I present. Specific complication can occur after device implantation. That include thrombus, erosion, infection, and unusual arrhythmia. We should follow well the patient at long term. I don't know what it means, but it should probably means that they need to be followed by a cardiologist somewhere after device implantation. And lesson 3, if I have more times, no, I can stop here also and come back after if you want.